So we all know what will happen if you get a positive, result. If the results show benefit, we will know a very high level of evidence that specifically laser atherectomy below the knee, is beneficial. If it's not beneficial, what do you think that impacts as far as below the knee intervention, above, or atherectomy in general? I know it's a little tough question, but
No, we think about it every day.
Yeah.
No, I mean, that's the beauty of it. That I have no fear of that at all. Because if that's the whole point of this, that we designed a trial that really is to answer this question. And if it's not beneficial, it's not beneficial. Like, that's that. Then we say, well, why? Like, why because, all the reason that money has been invested into this is because all the preliminary data, and there is tons of preliminary published data in large scale, groups, has shown that this will have benefit, and enough of a benefit. Because that's the other thing, right? In PAD, especially because of the cost of these devices, like, it's not good enough if it's like marginally X. It needs to be 1 or 2X better to really say this is worthwhile. And so, and then to justify the cost. And so, the best place that we've seen that is kind of in VAC therapy for wounds versus some of the skin substitutes. Like, yes, the skin substitute may decrease by a week your wound healing, but is it worth, the thousands of dollars? And it's not. But if it decreases it by a month, sure, it's worth it. Right?
True.
And so that's the same kind of concept. We want to be clinical here. And so in this particular case, if it doesn't show that, the real question will be, well, okay, overall it didn't. Is there a subset of patients, where it helps? A particular type of plaque. Maybe in CTO, not so great, but, if you have great, like 60 to 90% stenosis, because the laser, I'm just making this up. I have no idea. But
no, totally. No,
but
this is
something like that might come out. And then we might still be able to do what we came to do, which was answer the question, for what patients is their benefit? Right now, we're throwing the kitchens. We're saying everybody, everybody come through this. And that, I think that's really the cool thing about this trial, why I'm excited to be a part of it. But at the end of the day, even if this doesn't show that this made a difference, that doesn't mean atherectomy doesn't work. Because remember, this is just one type of atherectomy. Maybe orbital is different, or maybe. So I think people will jump on it. If they believe something and it sticks to, it works with their bias, they'll be happy about it. But I don't actually know if it will stop people who already use it from using it. You know what I mean? Like, will it change practice? I am not sure. I think it will change practice if positive.
At least it'll change arguments when you go to these conferences, and you can have something more to have in your ammo, right? I'm sure the trial is pretty, we won't get into the very, very specifics, but it's pretty detailed. Does it allow, often when we do these cases, we're kind of using several different devices or something, whether it be wet vessel prep or another type of adjunctive technique. Does the trial allow for that, or is it very specific to a single device in a specific disease setting?
Oh, great question. It is very specific, because in this particular first one, we don't want any confounders. So, if you were to use shockwave and then use the laser, and then, which I do all the time, by the way, in the above knee. Who doesn't? But in this particular, we're really saying, standard of care, gold standard of care is POBA. Compared to that, if you add atherectomy with laser, is it better or not? In terms of, ultimately we're saying, like, durability, right? Like, 6 months, 12 months. It is possible that at 6 months there isn't a difference, because, that, especially in this day and age. But at 12 months, again, because there's data published, and we all know this anecdotally too, that if a diabetic patient has a wound, it takes approximately 200 to 300 days for the wound to heal with good blood flow. And you can imagine if I do a POBA on a patient and I have a great angiographic result, and then I see them in 6 months and I do their ABIs, and maybe their toe pressure is like 5 points lower than it was before, I won't think much of it, especially if the patient doesn't have symptoms. But then 200 days later, the wound may not have progressed towards healing. In fact, it might regress. And what that probably means is that there was recoil at some point, and I don't have enough blood flow getting to the wound. And it never makes it. And then it gets infected, and then it has osteo, and then they get their amp.
Yeah.
And so the point of this is, like, I'm sure in the beginning, angiographically, everything will be great. But the idea is with the laser, that recoil ideally is not happening. And then you get that laminar flow continuously for the whole time that you need to get the wound to heal or to get the rest pain to go away or whatever. And so that's the other thing, by the way, kind of cool about this. Very important. We are not including claudicants. This is like limb ischemia.
Yeah.
No one is
This is limb
with that.
ischemia. This is tissue loss.
That's
tissue
right.
loss.
Tissue loss or severe rest pain, high Rutherford. And we're doing it based on Rutherford scaling. And there's a reason for that, because again, like, that's not the question here. We already accept in this trial, for this trial's sake, that we are talking about people who have bad disease below the knee that is affecting them, and they're looking at amputation in the future, potentially, if nothing is done about it, type thing. And so that's the patient population included here, so that we don't, again, have, you don't want to have a huge study that has everyone in it, and then everyone they were all claudicants, because obviously that shows things, and then that's going to just be a useless study.
Yeah, you basically take in, all the comments of prior studies where they're like, okay, well, so you really kind of honed down. And kudos to, you and Aaron and the entire team of the trial. Now you've enrolled your first patient. What's kind of an expected or hopeful target to enroll 200? And when we can get our answer, because I want to know the answer.
I like it. Now, me too. I think actually enrollment will be pretty quick. We've really selected sites that are quite diverse in what they do. We wanted to, and diverse not only in, who's performing the procedure, but also where, geographically diverse, and, hospital-based and outpatient-based, so that it's literally like what we do. Everybody, so you can't say, oh, well, all your centers were academic, so this is different, or, whatever. And we also are controlling some of the anticoagulation side of things too, so that, you don't get diversity there either, because that also has an impact.
Good.
Just trying to be really, specific. So with all that in mind, and given the number of centers, we're hoping for about 1.5 years or so. We really have to get things going. I would say, if you say in the next couple of months that, things are really moving, because we're doing enrollment of sites as sites are coming up. So it's rolling enrollment.
Okay.
And so actually, to the listeners, if there's anybody out there that would like to be a part of this trial, we would welcome you. And if you just want to get my email and unfortunately phone number is all over the internet. So feel free to contact me, and I'll put you in touch with our people. So freely.
No, that's great.
We'd love to have you.
No, totally. I mean,